Hello.
Hello, sir.
Can you hear me?
Yes, sir, we can hear you.
Okay. Okay. Should we just share the screen and check how is it coming in?
Yeah, sure.
Just for the let's check once.
Yes.
Share screen. What are we seeing there on the screen?
Oh, yeah, we are seeing management of healthcare
No,
facilities
no,
during the
doing the only the one slide are we seeing, or are we seeing the whole presenter view?
So we are seeing only one slide, but below we can see the rest of the slides also in a smaller view.
Okay, on the right hand side you don't see anything, right? The next
No.
slide which is appearing.
Yeah, so we can see the next slide that's appearing.
That's appearing also. Okay, then that doesn't work. Just to go to now it's only one
Yeah,
slide.
now it's perfect, so only one slide.
Okay, fine.
Yeah.
Okay.
So
Thank
we'll just take some
Sure.
time.
Yeah,
Now.
absolutely. Sure.
Yeah,
I just want
yeah,
to check.
yeah, sure. Thank you.
Hello. Hello.
Hello.
Sir, good morning, Dr. Sanjay Sharma.
No, I am Dr.
Yeah.
Bojana.
Uh,
Yes. Yeah.
uh,
You speak to Dr. Sanjay Sharma.
Yeah,
Yeah.
Dr. Sanjay is here.
Sir, good morning. I'm Professor Achit Deva,
Good morning.
coordinator for today's session.
Good
We'll
morning.
be starting in another 10 minutes.
Sure, absolutely.
Okay. Thank you, sir.
Thank you.
क्यों इसकी अब कर ले अब क्या लगा सो
ಆಧಾರ್ ಸ್ಕ್ಯಾನ್ ಮಾಡಿ ವಾಪಸ್ ಕೊಡ್ತೀನಿ, ಜೆರಾಕ್ಸ್ ಏನು ಬೇಡ.
Good morning. I am Professor Ajit Deva, and a hearty welcome to all the participants for today's webinar on healthcare. If anyone has any queries during the session, please feel free to use the chat box, and selected queries will be answered by our speaker. RNSIT MBA, established in the year 2004, is the brainchild of our beloved chairman, Dr. R.N. Shetty, who is a philanthropist by nature and has contributed significantly to the field of education. A number of educational institutions are run by the R.N. Shetty Trust, with RNSIT being one amongst them. With a continuous desire to provide quality management education to the society, Dr. R.N. Shetty has established RNSIT MBA department to nourish and produce the best of the managerial talents in the country. RNIT is one of the best accredited management schools in Bangalore. Now, I would like to call upon our HOD, Dr. U. Bojana, to introduce the speaker to the August gathering.
Thank you, Professor Ajit. I feel it's my immense pleasure to introduce today's speaker, Dr. Sanjay Sharma. Dr. Sanjay Sharma is the founder of Food Secure and Astra Labs. He is also the Vice President of Telemedicine Society of India. He is the Secretary, Indian Podiatry Association, and very significantly, he is playing a very important role as a mentor of NSRCEL IIM Bangalore. In December 2019, Dr. Sanjay Sharma was facilitated as Rising Star in Times Healthcare Achievers Award initiated by Times Group. On behalf of RNSIT MBA Bengaluru, I once again welcome Dr. Sanjay Sharma to the session. I request Dr. Sanjay Sharma to take over the session. Thank you, sir. Over to you.
Thank you, Dr. Bojana. Thank you, Dr. Ajit, and also Rakesh for inviting me to this session. I hope I am audible. Am I audible?
Yes, sir, you're audible.
Okay, so I'm just starting the slides. So and my screen visible?
Yes, sir, it's visible.
Okay. Thank you so much once again for this opportunity. It's a privilege to address the younger crowd, and especially when I heard, when I'm seeing almost 275 participants here who are interested in something to know about healthcare and how we are managing it. So when I was asked to talk about the healthcare in the pandemic, I was wondering. I'm not a front end. I wasn't in the front end in terms of treating patients with the pandemic that we are in today, the COVID-19. But for sure, I've been exposed to the hospitals and what they went through, and I was wondering, am I the right person? But I did make some efforts in terms of talking to friends across the country who have been in charge of the hospitals, who have been dealing with this pandemic across government and private hospitals, and also thought that I'd, and most of this, unlike when we're talking about some theoretical aspects and all those things, the most of the things that we are hearing from me today are people might have already read in the newspapers, in the news portals that has been there all over. So I thought of let me, instead of me putting in some gyan out there on the presentation and telling, I thought let me walk through the whole the management of healthcare facilities during the pandemic through a series of articles that was published in the newspapers. And so is my presentation is very much less of text, more of newspaper articles and headlines that you could see, which would make the basis of this whole presentation. Um, so let's begin with some key words. When I was told we need to talk about the management of healthcare facilities during the pandemic, so let's address what is management, what is healthcare facility, and what is a pandemic per se. Um, as per the guideline, probably you can use the chat box to ask questions. Happy to answer it at the end, or if it's something very urgent, probably you can ping on the chat box. Someone, one of the moderators should be able to stop me and ask the question. I'm perfectly okay either ways. So where do I know this? Okay. So the key words that we are saying today is the word pandemic, the word management, and the healthcare facilities. So I think management, you have been, all of your management students are faculties of management, and I don't need to talk about the management part of it there, but surely let's talk about what is a pandemic in today's context and what is a healthcare facility. When you're talking about pandemic, it's an outbreak of a disease that occurs over a wide geographical area that affects exceptionally high proportion of people, and we see that happening in the coming slides. We see how many people are affected already as on date. And management, sorry, I might be wrong here, you are the management experts, but is the art of getting things done through people, involving planning, organizing, commanding, coordinating, and controlling. And we're talking about the healthcare facilities here. I want to emphasize on this. So we're talking about two kinds of healthcare facilities. One is the public facilities and the private facilities. When we're talking about the public facility, we have the ASHA workers who are the front end workers for us. They are on contract with the government on a fee for service kind of a model. They go house to house in implementing various healthcare schemes that are adopted by the government of India, by the National Health Mission, or the government of Karnataka, or any of the state governments, so as to say. And above them are the auxiliary nurse midwife, who typically manage a subcenter. A subcenter is a center which is established for a population of about 25 to 30,000 people. So every 25 to 30,000 people has a subcenter, has an ANM, and has a team of ASHA workers who go house to house. And subcenter doesn't have a doctor per se, it is managed by the nurse. Above that, we have a primary healthcare center which has one or a two doctor, has a minimum inpatient facility, equipped to treat patients per se. Above that is a CHC, or a central healthcare facility. Above that is a district hospitals, where we see one hospital in every district. Across India, this is the same model that is being followed. Above that is the state hospitals. Like, for example, if I'm talking about Bangalore, being there, Karnataka being there, we have a couple of state hospitals, so as to say. We have the Victoria Hospital, the KC General Hospital, the Bowring hospitals in Bangalore. We have, being a larger state, we have a couple of state hospitals in Dharwad, Belgaum, and those places. And we have a tertiary care centers. Again, coming from Karnataka, I'd be talking about the hospitals in Karnataka. We have a tertiary care center, which is of predominance now in this context, is the Rajiv Gandhi Institute of Chest Diseases. We have a tertiary care of Jayadeva Institute of Cardiology, and a couple of them which are tertiary, which are system specific centers and hospitals. So this is how a public healthcare system typically works. And we will be talking about how each of these hospitals or the healthcare facilities were had to undergo a lot of changes when the COVID-19 pandemic came in. And we're talking about the private, which probably most of you are more well versed with. We have typical clinics, which is a 10 by 10 or a 15 by 15 place where a single doctor practices. We have polyclinics where multiple doctor practices in a single facility. Probably it is equipped with another X-ray machine or a small lab kind of a thing. We have a diagnostic centers, a chain of diagnostic centers that we would see. Uh, Lal Path Labs, kind of, or we have Ranbaxy and many of those diagnostic centers. We have nursing homes that are there in almost every taluka, a small place also, where probably a single doctor or a doctor couple kind of manages those nursing homes. We can call it as a mom and pop shops in the management terms. And then we have the secondary, tertiary, and quaternary hospitals. Like the Apollos of the world or the Fortis of the world, um, the Manipal hospitals of the world. They have across there in the smaller cities they have secondary hospitals, they have tertiary hospitals, and in the larger cities they have quaternary care hospitals. So this is how an healthcare facility is kind of spread across pan India, and we would like to discuss how each of them geared up for the new pandemic that has been there. And the first one, what we're talking about, the pandemic, is the today in the today's context. It is COVID-19. It's defined as an illness caused by a novel coronavirus. So it's called as a coronavirus disease 2019, and that's how the name comes in as COVID-19. Um, According to WHO, again, there is a bit of controversy. They saw the first case in December 31st, 2019, and by January 30th, it was an outbreak across the world, which had to be declared as a pandemic. So this is after the H1N1 influenza. This was the one that came in. As I said, we do not know. There have been various news articles, and here comes the a series of news clippings that we would say. It is said that the virus did outbreak in China in September, but it didn't come out to the world. The information was kept within China till December, and only in December, when they couldn't handle it within themselves, they told to the world that this is what has been happening. So there's been articles which said it was detected in December, and probably in India also. It's already speculated that it has already entered India in sometime in November, December, because if it was there in China in September, it could have entered. But officially, as per the WHO, it was December, end of December was when this was detected in China, and then it started spreading pan India, pan world, so as to say. So till today, we this is from the WHO and our own Karnataka statistics that we see. So till today, we have about almost about 7 million confirmed cases across the world, and we have about 400,000 deaths that we've seen across the world. And in India itself, we have seen about 1 lakh 12 1,29,917 active cases, and in Karnataka it has been about almost reaching up to 6,000 cases that we have seen. So this is a large scale of impact that we have been seeing with the COVID-19, and with so many cases, uh, all this deaths over the time, the confirmed cases that we are seeing, our healthcare systems, it could be hospitals that we talked about, weren't equipped to deal with such large population of diseased people who are coming with these symptoms. So you would say, no, this is like an influenza, this is like flu kind of a thing. But people in large numbers started seeking medical services where the world over the healthcare facilities were not equipped for these kind of numbers for them to see, and that is why uh, we require to rejig the complete healthcare system to ensure that this doesn't spread. So what was done was as the the government, the healthcare leaders started getting to know that we are going to have a huge number of people. The way it has been spreading all across, we got to know that we had to ready our facilities to get this huge number of people, and also we didn't know how would it in the early days. Today we know how it spreads and everything. In the early days, sometime in February kind of a thing, we really didn't know how this spreads. There were various uh, things that came in even from the WHO. Some said it spreads through the breath. Some said it spreads through the touch. So there was this various theories that were coming in at that point of time. So the hospitals sort of didn't know how to contain it, how it is going to spread, what will happen. So on one side we had to study the disease itself and figure out what is happening, why such huge number of people are getting these symptoms and getting positive for the COVID-19. And on the other side of it, we had to every day we had to build up the infrastructure in the hospitals so that we take care of these people who are seeking medical facilities. So once we got to know that this does spread by the aerosols or the saliva that we have when we are speaking, there would be a spray of saliva that comes in from your mouth, and it spreads from the aerosols, it spreads from the touch. Like if I have touched something, if I've touched a pen and give this pen to another person, if I had COVID-19 and the other person takes it, so he might also get it. So various of these things came up, and based on these, the hospitals had to create an SOP, create so that when the patients come to the hospital, they don't spread the disease. So you understand, the today's hospitals already have a set of patients. They're especially the government hospitals, public health hospitals that we have are already burdened with a huge number of patients. Apart from these patients, say for example they do not have COVID, they are not suspected COVID patients, and we have a huge number of patients coming in with COVID, we had to segregate them, ensure that the patients with the symptoms of COVID do not interact with the patients who do not have COVID. So there was some segregation that was required. So we had to identify and isolate the patients with possible COVID-19 symptoms. We had to take care of them as a part of the routine operations, potentially ensure that the large number of patients without COVID-19 are kind of isolated also, they do not get in touch with the COVID-19 patients. Monitor and manage any healthcare personnel that might be exposed to COVID-19. For example, I am a doctor, I have treated a COVID-19 patient, and now I have to go and treat another non-COVID patient. Then it was important so that I'm not infected. So I had to be all healthcare workers, the nurses, the ayas, the ward boys, doctors, everyone had to be ensured that they are also protected. If they get infected, then who would treat the patient? So that was a huge challenge that was coming up, and we had a comprehensive hospital preparedness checklist that came out on how to manage. And this checklist kept on evolving day by day. And we have this, with all these problems, we had early challenges. As I said, we had operational challenges. We had to ensure that the patients are segregated, the patients are screened. We had to ensure that that the human resources taken care of. As I said, the doctors, nurses, ward boys, ayas, security personnel, everyone had to be taken care of. They were the essential workers. Without them, we couldn't do anything. They had to be retained. So even the healthcare workers are human beings. They have their own scares. They will be thinking that Tomorrow, if I get infected, I go back home and I'll infect my parents, my kids. So I don't want to get infected. So I will say I will not come to the hospital for the next 1 week, 10 days, 15 days, whatever that is there. There is a fear factor even amongst the healthcare personnel. So we had to ensure that they are retained, they are trained in the new SOPs, uh, the new processes that we need to follow within the hospital. So everything has to happen. So there is no training period per se. The pandemic was spreading, the COVID was spreading, and the training had to happen on the job. And we didn't have a luxury of not getting trained, or we didn't have a luxury of not doing the job. There had to be a lot of supply chain issues that came up. So as the government started implementing the lockdown, and people might ask, from the clinical perspective, to the spread of the COVID, lockdown was necessity. We weren't prepared as a country. We weren't prepared for such large number of people seeking healthcare uh, services. So we had to ensure, the government had to ensure, apart from saying that the pandemic doesn't spread, on the other hand, we had to ensure that we had the necessary infrastructure to kind of cater to the healthcare services. So when that lockdown happened, the essential services had to be running. When we were talking about the human resource, when we are saying that the nurses cannot go back home because they're treating COVID patients, we had to ensure that they get accommodated in some place or the other. And if they're getting accommodation, they had to be fed. The patients had to be fed, the human resources within the hospital, the employees, the contractors, everyone had to be fed, accommodated. So there was a lot of challenges you as managers, in the sense, the coming managers had to handle. The hospital administration, the hospital management had to handle all this at one go. Probably as a doctor or a healthcare professional wearing a medical hat, what they would be concerned is, how do I treat the patient? How do I ensure that I don't get infected, or my team doesn't get infected, the patient gets well? But from the management perspective or the administrative perspective, we need to ensure that our medical team does its job perfectly so as to save all these patients. So the administration, the management had to take care of all the other aspects. We had to, going further, we had to take care of our revenues also. When we're talking about marketing, there had to be an innovation all the time. It was like on the go innovation, what we call it as jugaad in the Indian management terminologies. The innovation was the key there. So we'll get to see how all this happened. And apart from all this, safety and satisfaction, I'm calling it customer, but it's a patient here, of, of them was key. As we said, there were patients with COVID facility coming in, patients without the COVID symptoms coming in for the other ailments. How do we ensure that our hospital is safe for the non-COVID patients? How do we ensure that, if the fear factor was there, people started hesitating as the time passed by to come to our hospital, thinking that I might get infected by the COVID patient being there. So how do we ensure that the safety of the customer or the patient is taken care of, and he's also satisfied? So these were all the early challenges that we started facing in early March, end of March, once the lockdown started plugging in, and we had to change our systems accordingly. Again, so the government and the private hospitals pitched in. So within, you might have seen WhatsApp videos. I don't know about it. When it started off, the pandemic was declared in China sometime in December, and within about 10 to 15 days, in Wuhan, China put up 1,000 bedded hospital for these patients. It's like within 15 days, the whole infrastructure was built in. But in India, we're talking about, we weren't left behind. So everybody pitched in, and we had a But in Bangalore itself, in about 6,000 beds and 600 ventilators were in place within about 10 days, per se, for treating the COVID 19 patients. 586 hospitals pan India with 1 lakh plus beds were, put in place immediately, with around 11,000 ICU beds dedicated for the COVID 19 patients. Do we have a question? Somebody raised the hand. So even Maharashtra started, taking up, fast tracking the testing and ensuring that their facilities are kind of equipped with the for this. So all these things happened with a very short period of time. You could see, bringing in isolation wards, getting in all this 6,000 beds in isolation where they're not in contact with the other patients, versus and all the doctors, the nurses, and everyone equipped to treat. It is not an easy task. When we're talking about the doctors treating them, they need to be in a complete personal protection equipment, which you'll see the pictures as we go ahead. So it was not an easy task across, either to a private hospital or to a government hospitals. They had to establish fever clinics. So, so every crisis is an opportunity riding on a dangerous thing. So this was the key. How the hospital managers, everyone took the plunge together, saying that, okay, this is an opportunity, but this is dangerous, but we will go ahead with it. And across all the sectors, in a typical management school, probably you would read more than this. You'll be reading operations, you'll be talking about discussing strategy, you'll be talking about human resources, you'll be talking about customer satisfaction, and least but not the last but not the least, the revenues that is generated. And similarly was for the hospitals. If you're talking about the government hospitals, the private hospitals per se, revenue was the key. It couldn't be that I do free service as a private entity, or a public limited companies like Apollo or Fortis, which are answerable to their shareholders. And the change was required everywhere. So let's run through each of the aspects. When we're talking about operational changes, there was a clear new standard operative practices that was required in terms of how do we get the patient in. It cannot be like any other day where the patient directly walks into the hospital reception and says, I want to meet this doctor. We need to have to set up a screening kiosk in the front, where the nurses screen the patient. They talk about their travel history, their symptoms of fever, and all those things, and had to screen the patients then and there. If there was any symptom that we could see or any travel history that we could see, he had to be sent to a separate COVID OPD. He could not be sent into a normal OPDs that we could see. Starting from there, even then there could be asymptomatic patients. It's not that every patient comes with a cough and a fever kind of a thing. There are a lot of asymptomatic patients. So we had to address that so that none of the other patients are affected, or especially the doctors and the nurses, where they're exposed to every other patient. So we had to ensure that there is a certain SOPs of hygiene that is created, of utmost care. The doctors had to be ensured that they wear the personal protection equipment, completely cover themselves. After every patient finishes the consultation, the room has to be sanitized for the next patient to walk in. So various of these, and there were fears amongst the people. So can I do this? Can I do that? Can I touch that person? Can I touch the patient? So all these fears were there, and those, there has everything, or SOPs had to be rewritten. The rotation of the doctors, a it was a huge challenge to see the patients, because there was a whole set of new procedures, processes that needs to be adopted. Plus we had a huge number of patients coming in. So the existing medical personnel or the clinical faculty weren't enough. We and everybody were like with wearing all those equipments and all those things were tired at a very early stages. Like if somebody was supposed to be working for 8 hours with all this equipment, stress and everything, at sixth hour, fifth hour itself they were like completely drained out. So we had to as an hospital administrators, we had to create a new rota system on who is there at what time, so that we can cater to all the patients who are coming in and everything. As we discussed earlier, the supply chain. We're talking about PPEs, the masks, the gloves, everything had to be procured in spite of the lockdown. It is not that everybody was working and we can procure it. And with the government and everyone promoting that you need to wear a mask and the gloves and hand sanitizers and everything, the demand supply aspect came into the picture. The costs of all of these material rose pretty high, so as to say, as a except for the doctor consultation fee, what the hospital charges the patient, all the supply for the hospital raised. For example, a glove box, a non-sterile glove box, which costed about $300 for 100 pieces of gloves. Suddenly, the prices went up to 799 rupees. The masks, the surgical masks that we wear, which we used to get it about 3 to 4 rupees, suddenly raised to about 18 rupees. So there was new equipment that was required, like the personal protection equipment, where the whole gowns where the doctors is covered by it. So all those things need to be procured at a right price. We couldn't be giving in lots of money just because there's a demand supply gap. So that was a huge challenge for all the managers who are handling the vendors, all the managers who are handling uh, the supply chain part of it. This became a huge challenge which had to be addressed. I already discussed about the cost control, the infrastructure segregation. As we said, the hospital had to be literally divided into COVID and non-COVID. So for example, if a patient had to undergo an X-ray, and we would have in one large X-ray machine, or say an MRI machine or a CT scan machine, the hospitals would not have multiple CT scan machines. So there'll be one CT scan machine. And if a COVID patient underwent a CT scan, and if I need to take a other non-COVID patient to the same CT scan, there was always a fear that the non-COVID patient can be infected with the COVID. So the whole CT scan systems had to be sanitized before another patient goes in. So this was a huge challenge on how to prioritize, how to use the existing infrastructure for this huge number of patients, and that too segregated between the COVID positive and the COVID negative patients. And similarly was the logistics. Doctors, nurses lived far away. They traveled in public transport, and that day, the public transport wasn't there. And how do we ensure that our medical professionals come in and come into the hospitals? For many a times, we had to create lodging facilities within the hospitals for these nurses and the other paramedical staff. Um, the human resources again was a challenge where the change was necessary. The increased need of healthcare workers was obviously there with the increased number of patients coming in. There was training that is required, as we told earlier, new SOPs, new ways to deal with it. And it's a new disease. We don't know how to deal with it. One day they say uh, the HCQ medicine is the right drug. Tomorrow they say that is not the right drug. Someday they say plasma is the right drug. So the whole clinical training and the operational training, the way they work, had to be done on the job when we were treating patients and people were dying with it. Retention was a huge issue with the migration. So if you look at most of the hospitals, at least if I'm talking about Karnataka and probably even Delhi and other places, most of our paramedical staff, especially the nursing staff, are migratory. They have come from Kerala and Northeast, and most of these people have come in there, and all of these people had to get back home. There was this in the head that I need to go back home. I can't be like this. So we had to ensure retention. Uh, we needed more and more number of people, and B, people were wanting to get back home. We wanted to retain them also. We had to keep them motivated to come back to work each and every day morning, and ensure that you know they follow the processes, ensure that they don't get sick. And in all this we had to do because, and we also had to announce the salary cuts, because the hospital was not doing enough revenue for them to pay the nurses. Probably it was only one hospital, I don't want to name them, only one hospital which gave full salaries. Other hospitals, I have heard from my colleagues and other people, have cut almost about 80% of the salary, because they the hospitals weren't unable to generate enough revenue, like in the months of April and May. So all this had to happen, and keep them motivated, train them, retain them. I you should see the complexity of it. As managers, probably some of you would be managing the hospitals going forward, and these were the challenges that we had to see, and everything had to be sorted out then and there. We talked about customer satisfaction and how do we manage customer satisfaction there, and we had to ensure that the revenue is trickling in, marketing and sales is happening. It cannot be said that the hospital is shut, or we will not be able to also say that we charge an exorbitant sum of money for treating a COVID patient, and we can see that backlash of that in Delhi that is happening right now. So there is a fine balance that we have to ensure that the revenue is trickling in, the hospital is capable of running itself, at least the operational costs are kind of taken care of, and still all the other things are managed. And all of this activity was on the heads of the administration of the hospital, the key leaders in the hospital, and the implementation obviously came into at the entry level. So if some of you guys are joining the hospitals, you would be in a very entry level and positions, and you would be the people who are probably your seniors, whoever is in the hospital, might be implementing all this on the ground. So this was what we had to say, and the changes in across all this was absolutely necessary. The solutions already were coming in from across. There were innovations that came in, as we all have heard our prime minister saying, in terms of how India started producing our own mass producing the personal protection equipments, masks. So most of the industries converted their facilities to produce all these textiles. Even our beer companies, the alcohol beverage companies, started producing sanitizers instead of producing alcohol. So the whole system was kind of augmented in terms of solutions that they came up with. So every other incubation center started saying that, started inventing something for the COVID. Even BIRAC, the Government of India Biotechnology Department, also started incentivizing research for immediate implementation to handle this pandemic. There's also one thing that you could see on the violence against health workers. I'll come to this later when we're talking about what are the further challenges that we had to face, not only the ones that we discussed in terms of operations, human resource, and other things. So one thing that came into picture was the center permitted the doorstep delivery of medicines. Until then, there was a legal dilly-dallying between, does e-pharmacies, is it legal, not legal? There was a pushback from the brick and mortar pharmacies that you should not allow e-pharmacies to deliver medicines. So this changed the whole scenario. When a person-to-person contact wasn't to be there, people couldn't travel, the delivery of medicines became inevitable, and the center had to legalize the doorstep delivery of the medicines during the COVID-19 period. We're talking about the ESI hospital Coimbatore gets widespread praise. They did something unique very early on. They started screening for patients. They started their own isolation ward that came in before any of the hospitals could bring in, and they uh, kind of treated every patient that they had got. There were no mortality in this Coimbatore hospital till date, and the kind of social distancing they observed and within the hospitals was pretty unique, and they were kind of applauded. So these were the kind of innovations that keep coming in from different quarters. Each one was trying to do something different, something to help the population that came in. And telemedicine became the completely a new norm on March 28th. Once the lockdown was announced, it was imperative that the people had to seek medical help, and without seeking medical help, it was challenging. And until March 28th, telemedicine in India didn't have any guideline. It didn't say it is wrong, nor did it say it is right, and this is how you can practice. This is what the do's and don'ts of telemedicine. And on March 28th, thanks to Telemedicine Society of India for its lobbying and pushing, the government came up with a guideline for telemedicine in terms of how each of the doctors can practice telemedicine, in what they can do and what they can do. And this is one of the best documents across the world, a telemedicine policy across the world that you could see. Interestingly, US has HIPAA, that is the Health Information Privacy Act, and various other countries has its own privacy acts, and it had become very cumbersome for the telemedicine companies, telemedicine to provide telemedicine in US and other Western countries. But India has had learned from it and opened up telemedicine, saying that you can do telemedicine the way the doctor or the patient wants. Telemedicine can be practiced on using Facebook chat, using WhatsApp, making a telephonic call, need not have a separate portal for it, need not have a separate platform or anything as such. So it kind of opened up the whole system and said that it's if the doctor is comfortable, because by the end of the day, the doctor is liable. So if the doctor is comfortable, as the patient is comfortable, use any means to provide telehealth. But they did put some restrictions in terms of what medicines can be prescribed, what medicines cannot be prescribed over a telehealth. I don't want to get into that. That is more for the doctors per se. But from the management perspective, now the hospitals had to gear up to provide telemedicine services for its patients. They had to ensure that the patient do not crowd the hospitals, come to the hospitals. They had to set up screening systems over tele and say that, okay, you call us on this number and we will do a teleconsultations. We will screen you on telemedicine, provide the doctors access on telemedicine, and deliver medicines to your home post the prescription from the doctor. So this was another challenge. Even though it was for the good, this was another challenge that the hospital administrators and the chief information officers of the hospitals had to set up at a very tremendous fast-paced phase. And I see in one of the in the hospitals that we consult, the telemedicine consultations in April and May rose hugely, from almost about 100 times increase in teleconsults. And pretty sure this is going to be, with this new law in place and people having tasted telemedicine, both from the doctor's perspective and the patient perspective, this is going to be a new norm. India also became, especially Bangalore, became the hub of clinical innovations. And we started treating patients with plasma therapy. We started treating patients with various drugs. The Ayush department, or the Ayurveda, Yoga, Unani, these alternative medicines came to the forefront. They started providing medicines for preventive aspects so that the immune systems can be developed. And there was a huge acceptance of these alternative systems also. That's also a huge change. So today, just within these 2 months, the use of telemedicine grew hundredfold, and similarly the use of ayush, or the alternative systems, grew manifold per se. The So the private hospitals started putting in new SOPs as a clinical innovation. They said they are going to test for COVID-19 before every surgery. But in spite of all the private hospitals managing this, the government hospitals always stood at the forefront. So this is where you should see, in terms of when it is a pandemic, when it is comes to public health, it is the government machinery that takes the lead. So the complete 1,000-bedded Victoria Hospital was converted to a COVID-19 hospital, even though it was a challenge in terms of how do we deny services to the non-COVID patients. But they said, okay, these non-COVID patients emergency can be handled in other government hospitals, but this hospital is going to be completely for the COVID-19 patients. And most of the doctors there, whatever stream of medicine that they are in, they were assigned for COVID duties. So this is the kind of drastic steps that the government also took in and started implementing it. And as we as the number of cases increased, and as it is increasing even now, the challenges kept on growing. There, the non-COVID patients, as I told, the whole hospital became a COVID hospital. The non-COVID patients did not know what to do, where to go. They used to come to this hospital, they were sent back, go to the other hospital, kind of a thing. So there was a little bit of scrambling that we could see amongst the non-COVID patients. But surely with some, uh, you can take your management's 80-20 rule. So this intervention of making some of the hospitals completely COVID hospital, like for example, if you take in Delhi, the Batra hospital is a completely COVID hospital. The Gangaram's hospital became the private hospitals. I'm saying the Gangaram private hospital became a completely COVID hospital. So people started adjusting it, and this strategy was almost about 80% successful. The medical resources got completely strained. As I said, the doctors, nurses were working 12 hours, 24 hours to treat for the patients. And if they became sick, and many of the doctors, so you should see in the All India Institute of Medical Sciences itself, almost about 400 healthcare personnel tested positive. So when these healthcare professionals test positive, they need to get into quarantine, they need to get treated. So where do we get new healthcare personnel? So one of the strategies that the Mumbai Corporation took in, or the Maharashtra government took in, was they roped in all the private doctors. Almost 25,000 private doctors were asked to come in and take care of the sick in the government hospitals. There were backlashes for sure. I'm not saying that this was an authoritarian move, but at this time of a pandemic, these kind of innovative changes, challenges had to be required. And as I said, not just the solutions came in, not just from the government, but from every person on the ground to the government. The solutions were coming in. People were working every day and night to ensure that these gets implemented. And what this came up was including violence against doctors. You could have read in the newspapers that across various hospitals that we could see, private and public, when there was a stigma that was created, like we had a stigma against the HIV early on. So there was a stigma that was created with the people, saying that if somebody was tested positive, he's going to be quarantined. It was like people thought that I'm getting into a jail or something. There was a lot of misconception that that had built in due to the media, due to various WhatsApp forwards that we could see, and all this and meant that people were avoiding testing. People were avoiding quarantine, the word quarantine itself. So that we could see whenever the medical team went for testing in various parts of the country, they were beaten up, stones were thrown against them, and it was not that only this time it happened. This violence was there even previous to the COVID-19 also, but this violence against the medical professional came into the forefront, and immediately, as I showed earlier, the government of India ensured that they brought out an ordinance that any violence against the medical professionals is a criminal offense, and they will be jailed for about 7 years. And this was a major step that was taken again by the government, like the Telemedicine Act, the Pharmacy Medicine Delivery Act, the Violence Against the Medical Professional Act. All these acts that were pending for a long time kind of was passed during the last 2 months, and the frugal innovations came up. uh, as there were challenges, as there were innovations that were happening and everything. Hospitals started using artificial intelligence to screen the COVID-19 patients. There was a call center that was established called Step One, Project One. So where they screen the patients using AI facilities. The army doctors, the army came up with its own devices, like an anti-aerolization box, to ensure that there is no contamination in the room, the quadcopter. So all these things came up by the army. So everyone pitched in to ensure that we can fight the pandemic together. There were robots, like in Kolkata, one of the hospitals implemented robotic nurses. So the nurses actually did not have to go and visit every patient. A robot with a video camera and the speaking facility went to every patient, and the doctor did the rounds through the robots. And only for the patients which was absolutely necessary to visit, the doctor wore all the PPE equipment and went there. We were talking about the PPE. You can see the picture here, how the DRDO came up with its own PPE equipment. So all this time, these PPE equipments and the surgical gowns and everything was most of the times imported from China. And today, thanks to pandemic, that we have our own huge manufacturing facilities that can manufacture all this everything. Um, the government too was, the first time we could see a BBMP, the Bruhat Mangaluru Mahanagara Palike set up a war room. That was like the first in India, where there was a war room was set, and the whole the team was kind of managing the pandemic on a minute to minute basis, 24/7. This was unheard of in a government setup, where a war room with all the technology being there set up in like just a week's time, and till now it's been working. You can see their websites of the BBMP COVID-19 and how the war room is functioning even today. So there was the Delhi government launched an app. I know there would be, you're seeing in the news that it is not syncing very well and all those things, but the speed at which the change happened, the speed at which the innovation happened, is something that I would want to bring your notice on. Where a government launched an app syncing all the hospitals to ensure that they declare their number of beds, available beds, at 10 a.m. and 6 p.m. every day. And that kind of a coordination that needs to happen is huge, and that too at a short period of time. The hotels were converted to hospitals. The hotels were converted to quarantine centers. Again, that required a change of thinking. How can a hotel be converted to a hospital immediately? There would have been resistance. So a change management was put in place, so that all these things, they can convince the hotel owners to to change it to a hospital. They can convince the hospital administration to, you know, convert that hotel into an hospital. They had to convince the people around those hotels. People there, as I said, there was a stigma. People pushed back any quarantine facility within the neighborhood, was pushed back, saying that we will not allow COVID-19 patients to be there in our locality, in our apartment. um, Even doctors serving in the hospitals, when they went back to the apartments, they weren't allowed, saying that the doctors, you are not allowed because you might spread the pandemic. So with all those challenges, there was new and new laws that came in from the government, and the private hospitals also plugged in and started uh, doing change management innovation together. Again, a few more innovations that I would want to bring in terms of, in Israel, it was home hospitalization became a norm. They had home hospitalization kits that was delivered to the homes, uh, which included a teleconsult module that they started using. Up north, even in Kashmir, they started innovative ways to collect swabs without the nurses or the doctors being exposed to the patient per se. We had the the technology, the techies, so as to say, they set up a call center where 6,000 doctors were accessible on the call for the patients for free of cost. And these things, I was a part of this initiative of the project Step One. this this is a voluntary project. Nothing has been paid to anyone, but this was done within weeks. So that's the potential of the human. That's the potential of, if we want it, we can do it. Similarly, one of the hospitals in Tuticorin made a machine for better management of the patients. Even in the as we said, the processes in the Bangalore hospitals was improved in terms of testing, and we also saw the results. We can see, when you go to the statistics, we can see most of the patients have been recovered and sent back home. And all our medical professionals, the hospitals, everyone are kind of clapping to the patients who is going back home once they are recovered. So, and the rural hospitals, all this we're talking about, the rural hospitals couldn't, it couldn't change to a separate COVID hospital like we did it in Victoria Hospital in Bangalore. So the rural hospitals had to manage both COVID and non-COVID patients, and they were fighting this absolutely well, in spite of the lack of resources that we say, and the changes that they brought about, the frugal innovations that they brought about in the rural hospitals were worth mentioning. Yeah. And the smiles and happiness, patients started going back. But again, uh, as in when the number of patients started increasing, we had more and more challenges that we come in. The Mumbai runs out of hospital beds. The app that the Delhi government released wasn't functioning as it was intended. The app showed that there were so many beds available, but when the patient went to the hospital said the beds were not available. How do you transfer the patients from one hospital to other hospital? So so all these challenges are still coming up, and the hospitals, the healthcare facilities are managing it by the day. Every day is a new challenge. Every day is a new change. Every day is a new innovation that we see. And some good news. This was in yesterday's paper, where we are seeing that there is a herd immunity that is being developed. So it is the body itself has been developing immunity against the virus, and so probably we would not see so many patients heading to the hospital due to COVID in the near future. So how would be the scenario? Probably knowing that so much has been learned, so much change has happened in just last 2 months, in delivering healthcare, in screening for healthcare. So there would be a huge changes that we expect within the hospitals, how the hospitals function um, um, in future. So there would be medical imaging would be overwhelming. So anyone and everyone will be undergoing an CT scan or something, or an MRI, so as to say. So there will be high demand for the medical imaging. The medical technology, as I said, the telemedicine, anything virtual physiotherapy, virtual rehabilitation, chatbots, all of the digital technology, the digital health is going to be the future. This is going to drive the hospitals is going to reduce the contact as much as possible, because they have seen that this can happen. And the in vitro diagnostic services at retail clinics, malls, and airports will come in. Probably there will be screening clinics, fever clinics, respiratory disease clinics, and all these small kiosks might come up in across all the malls. And instead of going to a hospital, you can get it tested in various public facilities that is being there. So this, I see a huge change in the hospitals, the, the way it functions. The what I predict, probably in the future, in the near future, probably in about 6-7 years time frame, the outpatient consultations, where the patient have to go to a hospital and see a doctor for an outpatient consultation, would be redundant. Hospitals would be meant for acute care and surgeries and procedures, and all consults per se probably will be on the telemedicine or the digital health. This is what the future that I see for the healthcare facilities. Due to this pandemic, this has been accelerated. This was supposed to happen. Probably we were thinking it would happen in the next 20 years, but the pandemic has accelerated the change, and we see the change as a norm in the going further. In terms of just coming back to a management perspective, uh, how did the curve? So I see the curve, the HBR mentioned, gave this curve for the startups, so as to say, when the startups come in, they in the phase one, they're going to figure out the winning model. They're going to try various things. They will have a breakpoint, and they're going to figure out the winning model. In the phase two, they'll deliver that model efficiently. Their processes will change. They'll ensure that that model is kind of efficiently delivered. And in the phase three, we see that the change again. So the phase two will become a norm, and to be on the top, there has to be a new product, new service offering. There has to be a change. So this is the S curve that the HBR says for a startup thing. But the similar one, if I'm looking at from at the pandemic perspective, uh, so we experimented vigorously, broadly, to discover what works and how to streamline and improve the operations. So that happened in the phase one. We shared the results of the failures and successes quickly. So across the globe, what the hospitals did in US, in Russia, and China were put upfront. The results were shared so that we don't repeat the same mistakes to scale up and success. So that also happened. The document and formalize the processes is happening now. So right now there has been experimentation, new things that are coming in, and the documentation processes are in the phase two perspective. I think we are in the phase two model right now, in terms of we are documenting, we are formalizing the processes, putting in the processes in place, and probably at some point of time we had to revisit and reinvent these processes in the future. Forecast and planning would be the key in this whole processes that we the hospitals are putting in today. I would like to end this saying with a quick note, saying that adaptability is about the powerful difference between adapting to cope and adapting to win. And without adoption, we could not have overcome, or we could not have addressed this pandemic at all. And this adoption is not to cope, and this adoption to win. If you look at all the changes that are there, that has happened in the healthcare facilities today, we have changed to win. We are not changed to cope up. Thank you so much. Happy to answer all the questions now.
Yeah. Any questions from our audience, from participants? Please, if you have any queries, please type it in the chat box, and our speaker will be more than happy to answer them for you.
Somebody was raising their hands on the in between. So
Yes, Shruti JP, go ahead. Please unmute your microphone.
it says three participants raised the raised hand. So
Yes, Ms. Shruti, please go ahead. Yes, Dr. Anita, next speaker.
Yeah. Yeah. Good afternoon, one and all. So my question is that it's audible, sir?
yeah, sure.
Yeah. Sir, the previous slide, what you said about the S curve, right?
Yeah.
And we are actually in the phase two now, if I'm not wrong. As you
Yeah.
said, we are all sailing in the phase two.
Hmm.
And you have given us a statement like we need to adapt the model very efficiently. My question is this: there are a lot of challenges for a human being, as of you, for humankind, with regard to the health aspects, with regard to physically, mentally. There are a lot of things, a lot of challenges we need there, which are in front of us. Like, how, from your end, with your experience, what are the tips that you can best give so that we can try to face all these challenges in this phase two very safely? What are your tips from your end, sir?
Tips, the only tip is this is also will pass through. This is not such a a dangerous disease that we had seen earlier, like plague and things like that, or ebola per se. This will pass through. The only thing is we have to take it in our own stride. So the adoption today has been that we are conducting webinars instead of calling all the people into one hall and doing it. So uh, all the so I don't want to repeat in terms of what the media and the government and everyone has been talking about from the clinical perspective, in
Yeah,
terms
yeah.
of sanitize your hands. I don't want to repeat
Yes,
that.
sir. Yes, sir. Yeah. That's
But from the mental health
yeah.
perspective, and in terms of managing your stress levels and managing the change, for me, change is constant. If there is
Yes.
no change, there is no life. So you'll have to take it, at least my thing, like, take it in the stride, in terms of this is a new learning experience for us. We today we know exactly what is absolutely essential for us. Having looked at the last 2 months where we are living with essentials, we have passed through this phase of 2 months of lockdown. We know what is essential for us, so that's a learning. So
Oh,
we know how to manage things without certain aspects. We know so there is I would take it personally as a learning curve for me,
mhm.
saying that this is what I learned in the next 2 months, and probably that would be helpful in me implementing it for the rest of my life.
Okay, sir. Thank you so much, sir. Thank you.
Thank you.
Any other questions from our participants? Okay. At the offset, I would like to thank the management, the director, principal, and registrar for their continued support in conducting this webinar. I also like to thank our beloved HOD, Dr. U. Bojana, for his encouragement in conducting this event. I wholeheartedly thank our today's speaker, Dr. Sanjay Sharma, for sharing his valuable and rich experience. Thank you, sir. My special thanks to our sponsors, Business Standard, the Karnataka Management Association, and Vision Digital India for their support. Last but not the least, I would like to thank our participants for attending this session. Now, I kindly request our participants to fill out the feedback forms which have been sent to your respective email IDs, following which you will receive an e-certificate for today's session. We kindly request all the participants to attend our evening session on democratizing analytics from
ಮೇಲ್ ನೋಡ್ತಾನೆ
RNSIT.
ಇದೀನಿ, ಬರ್ತಾ ಇಲ್ಲ ಯಾವ್ದೂನು ಇನ್ನು. ಈಗ ನಮ್ಗೆ ಯಾವ್ದು ನನ್ನ ಪರ್ಸನಲ್ ಮೇಲ್ ಐಡಿ ಕಳ್ಸಿದ್ರಾ?
From RNSIT MBA, we thank you one and all. Thank you.